Okay, I'm here to talk about Mbrace, the project that had been carried out by Mike McCurdy and his Mbrace team of nurse specialists, breast cancer nurse specialists. This programme started back in 2009, and it was actually based on Dr. Anna Campbell's work, and actually I think you consulted, didn't you, with them at the time? So a lot of it is based on Anna's work, and you've probably heard a bit about that already, so I won't bore you too much. I'll skip over anything that Anna's already covered. I was brought in only last year to try and put together that data and see where we were actually at. They had collected as an audit project 3 years worth of work, 3 years worth of forms. They were all in boxes. They'd all been handed out to audit to collate into a database. And I had been handed the boxes and the database, and everything was all over the place, and told, right, now try and analyse this and bring it all together so that we can see where we are. So I came in rather late, unfortunately, but I do, how do I get out of that? I do feel that very involved now, and I do hope that it's something that I could actually go on and pursue and get more involvement with as the programme carries on, because it's been so worthwhile. As I say, it's based on Dr. Anna Campbell's findings originally from the work that she did back that you saw in 2007. And we used very similar forms, as I'll talk about in a minute. Funding was from Macmillan Cancer Support. They initially gave the funding, and it was supposed to be for 3 years as an audit project, and it's still going on. I'm happy to say it's just past the 3 years, but they had a huge waiting list, and we are still getting patients that were on the 3-year programme still actually being put through because of the waiting list. So we've carried on into another year because of that waiting list. So that's good, that's great news that people are actually keen to come forward and do the programme. They want to do the programme. The programme itself is a 12-week exercise class, and this followed treatment. I'll talk about that again in a minute. And the assessments are carried out at both baseline, before they commence the exercise programme, at 12 weeks and at 12 months as well. So, I'm used to having a Mac. No, I'll get there, don't worry. So I keep going to the wrong button. Yeah, I'm okay. Just that one, yeah. In the space bar. It's okay. Mac users, sorry. The management of the programme itself was led by personal trainers at level 4. They actually run the classes, so level 4 cancer rehabilitation course, an excellent course that gave them the baseline knowledge to actually work with patients with cancer and know the types of exercises to do with these patients with the background knowledge that they needed to get them there. The Mbrace nurse specialists themselves, they were all based at each site as well. The hospital premises also provided a safe environment for that patient to actually do the exercising in, usually taking place in the physiotherapy gym halls. Based at the RAH, based at IRH, and based at the Vale of Leven, these programmes had all run, are running, still running. All patients were invited to participate that had a breast cancer diagnosis, every one of them. The only ones that were excluded, and I'll talk about shortly, did have exclusions because of metastatic disease or other indications why they shouldn't. I'll list them shortly. The minimum of 4 weeks following their last treatment included chemotherapy, surgery or radiotherapy. They were allowed to go on with the programme if they were on hormonal treatments. So they had to have at least 4 weeks clear. The rationale for that was actually based on literature at the time that said that they'd have a better uptake of actually exercising if they did it well after the treatment had ended, because it was too much of a fatigue or an element of too much of a problem while they were actually going through their treatment. And I know that Research now proves that that's not the case, and we should be doing more during treatment, before treatment, following treatment immediately, not waiting the 4 weeks. But that was based on the knowledge and the beats and initiatives that we had at the time. We actually thought we'd have a better uptake rate if we did it well after treatment was finished. The exclusion criteria were very, very small. Approximately 10% were not invited, and the reasons were that they were unlikely to complete the programme because of metastatic disease, or they were in long-term residential care, in psychiatric care, or maybe had dementia or Alzheimer's. So that was really the only ones that were not invited to participate. Everybody else had the opportunity. The programme itself started off with a warm-up to get everybody loosened up. I actually can say I observed it and it was absolutely fantastic, and I even wanted to join in. It was so good. It's an excellent class. In no way would you think, oh, this is just for cancer patients. Anybody could do it. It was a wonderful class, a normal exercise class. The warm-up was fantastic. Circuit exercises tailored to individual needs, and that was individual needs because the breast cancer nurses and the personal trainer had communicated with each of the clients or the patients beforehand to explain to them what they were going to do and explain to them what they should and shouldn't do, and to tell them how far to take it. Some people were up standing doing their circuits. Some people actually needed to sit down, but they were still doing their circuits while they were seated. So whatever level of their individual need was, that programme was tailored to. Nobody felt that they couldn't do anything at all. Everybody participated in some way or another. They also included a cool down and a relaxation period of about 10 minutes where they all lay down and relaxed and were taken through a meditative process. And I thought that was actually a lovely way to actually end the programme. And I was talking to the patients afterwards, and they said that it's probably the only time in their day that they felt they had to themselves to relax and could think and just lie there and think and feel themselves. Now I thought that was really nice and actually quite emotional for some to, you know, to be able to just have that time. It's the only time in the day that they could have, that short 10 minutes. So not a long time to have when you feel, you know, you've got other things pulling on you and your health's pulling on you, but you've got that 10 minutes. They loved that. They loved that aspect of it. It was also after that, they had a rotational series of advice sessions where the nurses themselves had organised a programme of people to come in and talk to them about various aspects of elements that they could use for further advice for health promotion, such as sexual health, such as diet, such as nutrition, all smoking advice, that type of thing. So these were organised on a rotational basis. So over the 12-week programme, they at least were able to attend one or two of the sessions on whichever ones they preferred, or all of them if they attended them. So that, I think, was also a really unusual element of the programme that kept people there, because even though I was speaking to some of them during these sessions, a lot of them said, I know I'm here for the exercise, but I'm really interested in what they're talking about today. That's more important to me today. I wasn't going to come for the exercise, but I really wanted to know what they were talking about afterwards. That's dead important. So to have all of these elements in a package actually kept the people coming. It kept the retention rates very, very high. People wanted to come back for that, for something. There was always something there. The other important element that I want to actually look at this in more detail later on, because we're actually going to go into some of the nursing records and find out what advice was given, what qualitative elements have come out of that. But the nurses were there at the start and at the end of the sessions, and what I noticed was the queue of people waiting to talk to them before and afterwards, which I think was also very interesting, an important element of that package and that programme. So it kind of fulfilled a lot of things. It wasn't just exercise, there was a whole lot of other essential elements in there that kept people coming back, that kept people going to these sessions, kept them interested. The duration of the whole thing was an hour and a half. Which again, that's a long time out of somebody's week to actually get there every single week for a whole hour and a half. The methods of assessments that were used We had pre and post fitness tests, the stand sit test and the step test, and these are usually your basic circuit tests that you will get even in any exercise situation where you want to do some basic fitness levels assessment. We also had shoulder, ranges of shoulder motions, obviously important for people that have had lymphatic surgery and the ability to move their arms afterwards. The self-efficacy tool that Anna had talked about, the rating for walking confidence in their ability to walk from 5 minutes to 30 minutes, and it was a rating scale of how confident they were in each of these 5, 10, 15, 20, 25, 30 ratings. Then self-efficacy rating for exercise, for the barrier method, and it was really the confidence they had to exercise maybe when they felt sick or when they didn't have time, when time was limited, when they were tired that day. So again, it was putting the ownership back on them to assess how confident they were that they could exercise in all of these elements of health. We also used the FACIT or FACT forms, and FACT is the functional assessment of chronic illness and therapy, and these forms looked at, broken down, the FACT G, it's called the general FACT form, it looked at physical well-being, social well-being, emotional well-being and functional well-being. So that form was a self-fill-in questionnaire that they took home, the baseline at 3 months when the programme finished and 12 months later, well after the programme finished. They took these forms home to assess. The fatigue scale was also one of these forms. That was an additional rating scale where they rated how fatigued they were, and different questions to actually assess what level of fatigue they had with a total rating score. They had also a breast cancer specific scale that was related specifically to elements of breast cancer, surgery, lymphedema, etc. And they also had an endocrine system related scale, and that was to do with things like for the endocrine system, such as nausea related, sexual function related, gastric function related. So we had these assessment forms to do as well. Can I just say they were sent out, and what we found, that we had a total of 270 participants actually were invited to the programme. These are the different sites that you can see. The number of people that actually participated out of the 270 at the moment, from just year 1 and 2, I think I've got another 100 to get through to add on to this, was 130. So 130 people have gone through the programme in the first 2 years. Non-participating, about 81 didn't participate, 10 unfit to participate, and 49 not recorded as to what the reasons were, whether they wanted to, they were unfit, or whether they just didn't participate for other reasons. The age range was anything from 34 to 92 of the participants, which is absolutely wonderful. The initial forms that we had completed, 115 forms were completed, that's out of the 130, which is actually not too bad considering they're doing it themselves. I think that's the hardest part. If I had to revisit the actual programme, it would have been great to actually have somebody to sit there and do it with them at baseline at 3 months, and then to go out and visit them at 12 months. And I think that's the biggest limitation that we found in this study, because for the completed stage out of the 130, we only had 56 at the 3 month phase over the first 2 years. It could be much more than that once we get through these other ones. And for the 12-month stage, we only have 26. And for the baseline, the 3 month and the 12, we only have 8. So very disappointing, but I think that's the problems you have with self-completion questionnaires. They're posted out, especially at the 12-month when they're posted out. People are still not coming back at that point unless it's at their follow-up, or they've seen at their 12-month follow-up, given the form, but asked to post it back, and they don't. And I think that it would have been nice to be at that stage there, out there saying, I'll fill in that form with you. The other thing about the forms is we had a lot of people actually write on the form. I didn't understand this. I didn't know how to fill it in. Too complicated. So we had a lot of. Did you find that at all, Anna? That you had seen?
We sat with them.
You sat with them.
So it was done by a researcher sitting down in a room.
Excellent. And I think that in retrospect it would have been lovely to have that. But as you've talked yourselves about already, you've mentioned the restrictions in time and how the staff they didn't have the time to sit down and do that with them. I think it was an opportunity missed. But certainly in retrospect we should learn from that. If you're going to do something, it is very important, I think, that somebody sits down and literally doing the forms. They only take a few minutes, 5 minutes maximum, to get through the whole lot of forms. So it's a shame that that wasn't actually done at the time. Preliminary findings, however, 40 out of 44 that returned the sit to stand test. We've still got loads of these to go through, so this is just what we've got so far. 44, the red there is their post, and you can see there that there was actually only 2 in all of the patients. Out of the 44 patients, there was only 2 that didn't actually improve. The rest of them actually improved in their physical status from a sit to stand test. So that was excellent, and the average of that was a 7-point increase. So, and you can see there from some of the peaks, some of them improved really quite well actually. So that's good for the physical aspects. For the step test, very similar again. In fact, a little bit better. There was nobody that didn't improve. All 44 improved in the step test, and as you can see, some of the improvements were again high peaks there in the reds, where they did very, very well. And the average for that was a 9-point improvement, so 2 points more than this sit to stand test. So that another good physical improvement. We were really, really pleased with the results from that. Here we see, now these have not been statistically analysed yet, so I'm just giving you preliminary findings of what we're visually seeing. So there's no significance testing here, but it's just so that you get a vague idea from the stats what we have found. The red line is the 0 mark, so you can see that the trend is actually well above the line, even though we've got some of the patients below the line. There is a trend in the quality of life in the general fact forum that it has actually improved by 2.5. Now I know from reading some of the stats that it's not very significant of an improvement, but it does show a trend at the first 3 months that there's hope for improvement there. For the fatigue forum of quality of life, we found again that the average for this was actually a lot better. So fatigue, and I think that relates to previous research, that fatigue did seem to improve better than general physical, social, functional well-being. The fatigue did improve the levels of that. So we had a much better reading from that.
If that is statistically significant, that I think it's over 4 is a clinically significant difference.
Excellent.
Important difference.
Excellent. Oh, good.
So if it's significant, then that's
That'll be even better. As I say, we haven't done any significance testing yet, but the mean is 6, and we think that is actually, really good. But from that, we can actually see, and I think that relates with a lot of the literature. They don't find from the FACT-G forum, the general forum, they don't find much improvement in quality of life for the general issues, but they have found quality of life improvements for the fatigue issues. So it does actually relate to the current literature. So I'm really actually pleased when I saw that. I thought, oh, good, we're actually in line with everybody else. Really pleased. For the breast-specific form, not much of a change here, 0.73 of a difference. But remember, this was only 4 weeks after their programme that they did this exercise programme. So this is them at 3 months, and as Dr. Campbell said, it could be up to 6 months to a year to actually see improvements in quality of life from these issues when side effects from treatment have actually died down. Because at this point, these side effects from the treatments are still very much in people's systems, even though they're exercising they still have the side effects of swollen arms, drug treatment, they might still be on Herceptin, they might still be on tamoxifen. So it could be a while before we actually see a quality of life improvement on these issues. And the same with the endocrine system, an average of 2.32 of an improvement for that one. But again, the trend did seem to be above the line. So again, there was hope that once the side effects died down in the endocrine system, that we could see better improvements. Now, because we've only done the first 3 months, we haven't looked at the 12th month stage yet, even in the preliminary findings. We are hoping that as your research shows and other people's research shows, that as time goes by, we will find that the quality of life has improved for patients. It's certainly just glimpsing at it. What I did see, and it's very similar to what you said, is that the physical effects have actually been maintained for the 8 patients that we had, and the quality of life has improved. But again, because we've only got 8, I didn't feel it was significant enough to actually present it at the moment until we've actually got the rest of the data in and we've got a bigger picture of what's actually going on. But it does show similar trends to previous literature, which I'm very happy with. Range of shoulder motion. This was actually a fault in the forums that we actually looked at later on. Once they'd been put in, we realised that the person that had been putting them in had not separated it to the actual limb that had been affected. Now, if we'd actually separated it to the limb, we might have actually seen some significant data here. And I think we now need to go back to the forums and start again and actually separate it into the left limb and the right limb so that we can actually identify if improvements had been made. And I think that was because nobody had been there at the start, as you say, a researcher in post to actually sit down and put in the data. This was input in by audit personnel, so they didn't realise that they should be actually looking at which arm was affected and did that separate that into which score they should have for left and right side. So we will go back and look at that. We will revisit that. So ignore the findings. For the self-efficacy scales, we've got a mean of 3.6. Now, that correlates with what Anne said earlier, that confidence does seem to have an indication. As you see, some of them are very, very high indications as to confidence. They've more confidence to exercise. And if you actually read the comments on the forums, we're finding people are saying, I wouldn't have exercised if I hadn't done it here first. Now I'm happy to know that I can exercise. I am now going walks. I feel confident to go walks and really push myself. I wouldn't have done that before. So providing the safe environment at the hospital to exercise in gave people that confidence to actually go out and exercise out with the hospital programme. So their efficacy did improve. So 3.6 at the moment, but it could be higher when we see the rest of the forums. The walking scale had a fantastic improvement, and as I say, that was up to 12, so a really significant improvement here at 3 months. They were actually confident that they could walk now up to 30 minutes vigorously, which is a great improvement from their baseline, so we're really pleased at that. The next stage really that we're at is now entering the remaining data. Exploring the nursing records now for the qualitative. As I say, some of these forms have got comments on them, so there's qualitative data in the forms that we need to now bring together, as well as look at the nursing records for because every time they saw the nurses at the clinics, the nurses documented that, so we've got that to actually pull out now. We've also got to analyse the data in collaboration with a statistician for significance, and we then want to compare the results to other research to see what we're comparing. I mean, at the moment it does look very significant. The same sort of findings that we're getting is the same as what we've seen in other literature, such as yourself, Anna. We obviously want to publish the findings and share any good practice and continue the Mbrace programme. and there's lots of what we found. There's lots of opportunities for further research here. The nurses themselves feel that there is much more qualitative and psychological issues that they want to actually explore, especially in the consultation areas. They actually, and as you say, there's a dearth of literature there that we actually need to start adding to. So there is, the girls are all already looking at ways to improve that and do future programmes on that. I think the other good thing is that Mbrace is still going on, and we hope that after we find the results that we continue to get the funding and then we continue to actually run the programme, if not with the funding, that the NHS are hoping to carry it on. Well, they've not said no yet, and it's still there, so we'll keep our fingers crossed that long may that continue, and hopefully the message goes out. We're looking forward to seeing the 12-month data. As I say, from the 8 that we've seen, they are still exercising, which is great. We hope to see that actually follow through with the rest of the data that we're getting as well. And that's it. Thank you.